Hello, my name is Donna Tippett, and I'm presenting dysphagia management in individuals with tracheostomies. There is an accompanying PowerPoint presentation with this webinar, and you may use that as your handout to follow along in the presentation as we move forward. The first PowerPoint slide includes my speaker disclosure statement. I am an assistant professor at Johns Hopkins University, as well as an adjunct faculty member at the University of the District of Columbia, the University of Maryland, and Towson University. I receive royalties from Team of Medical Publishers, and I have received financial compensation from ASHA for this presentation. My non-financial disclosure is that I'm an ASHA member. So we'll begin by talking about this population in general first, and then we'll move on to talk about evaluation, some of the limitations and advantages of different evaluation approaches. We'll talk about speaking valves and their implications on swallowing, and then I will close by talking about education that speech-language pathologists provide to patients and family members. Throughout the presentation, I will give some interim conclusions, which are the take-home points for your clinical practice. So dysphagia is a common problem in this patient population, and it is important for speech-language pathologists to be able to identify those individuals who are at greatest risk, and also for us to be able to institute interventions that minimize and hopefully prevent many of the consequences that are associated with dysphagia. So this is a complex patient population, and the evaluation is often a clinical challenge, and this is in part because of the heterogeneity in this patient group. On this slide in your handout, you will see some descriptors of different patients that are representative from my clinical practice and perhaps your clinical practice as well. You'll see that the age of the patient population varies. So I've included one example of a 21-year-old man with a history of anoxic brain injury, as well as an older adult, a 71-year-old man who is status post brainstem stroke. So we've patients in young adulthood as well as patients in, from my perspective, late middle age. So in addition to a variety of ages, we also see patients with a variety of medical diagnoses. A common reason for tracheostomy is a neurogenic etiology, and that is perhaps the most common reason that tracheostomy is placed. So again, I've given some examples. Certainly our young man with anoxic brain injury would fall into that category, and our gentleman with brainstem stroke. Perhaps a less common example would be a middle-aged man with cervical dystonia. So those are some examples of neurogenic etiologies. In addition to that, speech-language pathologists see patients who have who are post-surgical. So one example would be a young woman who is status post decompressive surgery for Arnold-Chiari malformation. Another example would be a middle-aged man status post coronary artery bypass graft. A second common etiology in this patient population would be people who have head and neck cancer. And that would include patients who are undergoing surgery to treat their head and neck cancer, as well as individuals who are receiving non-surgical treatment, such as concurrent chemoradiation. And then finally, we see patients who are post-intubation, who have post-intubation trauma, and because of that, long-term tracheostomy is needed. Speech-language pathologists know that the consequences of dysphagia are profound, and I've included several examples in your handout. These might include aspiration pneumonia, weight loss, malnutrition, susceptibility to other illnesses, poor wound healing. So there's a variety of health implications. In addition to that, the consequences of dysphagia can be manifested as implications for quality of life, and those can be difficulty with return to the home environment, needing a variety of modifications to facilitate safe swallowing that make meal times a challenge. So these consequences that I've included in the handout are not specific to patients with tracheostomy, but are certainly implications for this patient population that we want to consider as part of our evaluation. We also know that there are a number of general prognostic indicators that affect how a patient will proceed during evaluation. We would consider the age of the patient, perhaps older patients having a more difficult time with return to oral intake or being able to institute some of the compensations that we use. We would consider the medical acuity of the patient, as well as their cognitive and language status, and their nutrition status and return to oral intake, the interval of time perhaps that the patient has been NPO. So these general prognostic indicators are things that apply to many different patient types that we see, not just those individuals with tracheostomy, but again, we would consider these prognostic variables when we're conducting our evaluation. Specific to patients with tracheostomy, I have included some implications that are both those that are generally agreed upon, as well as implications that lack a consensus, if you will. So I think first we would all agree that having the tracheostomy cannula provides a much needed access for suctioning. A second generally agreed upon implication is that the tracheostomy cannula eliminates effective cough. So two examples would be a patient who has a tracheostomy cannula with an inflated cuff. So when the cuff is inflated, the patient is not able to generate a cough to clear the upper airway. Patients also cannot generate an effective cough to clear the upper airway when the cuff is deflated, but the cannula is not valved or capped. And then finally, the tracheostomy may have implications for the integrity of the trachea itself. Without appropriate nursing and medical care, there can be damage that is incurred to the trachea, such as softening of the tracheal cartilages from overinflation of the tracheostomy cuff. So those are some of the generally agreed upon implications. There are other implications that really lack consensus. So one example would be that the tracheostomy cannula may tether laryngeal rise. Laryngeal rise is important, as we know, that in terms of protecting the airway. So the larynx elevates and moves forward when we swallow. Some have postulated that the tracheostomy cannula tethers that laryngeal movement. A second implication may be that the tracheostomy cannula desensitizes the larynx. So patients who have tracheostomy are inhaling and exhaling through the tracheostomy cannula rather than inhaling and exhaling through the larynx. Because airflow is diverted away from the larynx, people have postulated that this results in a desensitization of local receptors in the larynx, and that this potentiates the risk for silent aspiration. And then a final example of an implication for which there may not be consensus is that the tracheostomy cannula can impair the glottic closure reflex. And again, this would have an implication for airway protection. So those are some general implications of tracheostomy for swallowing function. I also wanted to point out some particular prognostic variables that are identified in more recent literature. So one example would be prolonged intubation. I've included two references, one by Leader and colleagues, and the second by Ajemian and colleagues. Both groups found that almost half of their patients who had prolonged intubation had swallowing impairment and aspiration. In both articles, prolonged intubation was defined as being greater than 48 hours. A second implication is prolonged mechanical ventilation. And again, I've included two references, one by Barker and colleagues, and a second by Mocht and colleagues. The Barker reference indicates that patients who have had prolonged mechanical ventilation have a greater risk of dysphagia. And in that patient population, these were cardiac patients who had undergone surgery. In the Mocht reference, those patients were critically ill patients. And then finally, there's the issue of disuse atrophy. In 1990, Michael DeVita used the term disuse atrophy to describe the swallowing impairment that he observed in individuals who required mechanical ventilation over a prolonged period of time. So his thought was that these patients had swallowing impairment because of a delay in return to oral intake. So patients weren't using swallowing muscles over a long period of time, and as a result had dysphagia. We are reminded that while we do need to consider the implications of tracheostomy on swallowing function, that it is important to bear in mind the underlying etiology that necessitated tracheostomy in the first place. In your handout, I've included two quotes, one by Leader and Ross in 2000, and a second by Donzelli and colleagues in 2005. So their point is that aspiration status or laryngeal penetration did not change whether a tracheostomy cannula was in place or if the cannula had been removed. So their point, again, is that we need to consider the underlying medical etiology in addition to the implications of tracheostomy. I'll take this time now to make some interim conclusions. So the first, again, is that we want to investigate the duration of intubation as well as the duration of mechanical ventilation support. We want to identify that information from our review of the medical chart prior to seeing patients, and then consider the prognostic implications of those two medical interventions. We also want to consider the underlying medical etiology in addition to the implications of tracheostomy. So those would include both those generally agreed upon implications as well as those for which there may be a lack of consensus. And finally, remember that dysphagia is likely multifactorial, and we want to direct our interventions to address the underlying mechanisms of the swallowing impairment. I'll move on now to say a few things about evaluation. Speech-language pathologists know that our ability to detect aspiration, predict aspiration at the bedside is limited. And there are a number of references in the literature that make this point. We also know that there is an extensive literature that describes clinical correlates that we may use to help improve our predictive ability. Many of these reports document that it is both the presence of abnormal cough, that is, cough after swallow, as well as the presence of abnormal phonation, specifically wet, hoarse phonation after swallow, that are suggestive of aspiration. So we can use those clinical correlates to our advantage, obviously with a variety of patients with dysphagia, but also with our patients who have tracheostomy. In addition, the tracheostomy cannula is a window, if you will, to detect aspiration. And many clinicians have used this window to their advantage by conducting the modified Evans blue dye test. The modified Evans blue dye test involves dyeing liquids as well as solid foods, typically with blue food coloring. Patients consume these blue dye foods, and then after that the patient is suctioned. The suction catheter is then inspected for the presence of a blue tint in the secretions, and if that occurs, then we would conclude that there's been an episode of aspiration. Many reports in the literature have shown that the modified Evans blue dye test is limited in its ability to detect trace aspiration. And so we are cautioned that the blue dye test should really be used as a screening measure to detect greater than trace aspiration. Now, certainly the ability to detect trace aspiration is important for some patients, but it may be of variable clinical significance depending upon the patient that you are seeing. In your handout, I've given a clinical scenario. So this particular patient is a frail, elderly patient with tracheostomy with many medical comorbidities. The tracheostomy tube has been changed to a cuffless tube, and the medical team wishes to remove the nasogastric feeding tube and advance the patient to oral feeding. You evaluate the patient using the blue dye testing and identify faint but present blue-tinged tracheal secretions in the suction catheter. So you must consider your recommendations at this point. Are you recommending that the patient have a peg placed? Are you recommending a particular diet or compensations? Are you recommending that the patient have an instrumental evaluation? The detection of trace aspiration may be very clinically important in this particular patient because of the other prognostic variables, their age, their other medical illnesses and conditions. And of course, we also want to be sure that we've investigated the need for prolonged intubation, prolonged mechanical ventilation support, because we've identified those as important prognostic variables. On the other hand, a young patient, let's say a young patient who has had an injury, a trauma, but prior to that enjoyed excellent health, and you're asked to evaluate swallowing in this particular patient, and you conduct a blue dye test and again identify trace aspiration. The identification of trace aspiration may have less clinical significance in a young, previously healthy individual. Another adjunct that we can use at the bedside is pulse oximetry. So clinicians use pulse oximetry to measure oxygenation saturation. Any episode of desaturation would be suggestive of the occurrence of aspiration. I have references in your handout that show that pulse oximetry is useful in the diagnosis of aspiration. And some have suggested combining pulse oximetry with various water swallow tests at the bedside as a way of identifying episodes of aspiration. We do know, however, that episodes of desaturation can occur for a variety of other reasons. So coughing would be an example, a change in posture, a change in temperature, poor circulatory status, and I've identified some others in your handout. So we need to be aware of those other variables when we're interpreting desaturation as measured by pulse oximetry as a measure of, or as an indication rather, of aspiration. The final thing that I wanted to say about evaluation is the use of fees in this patient population. I have many references that describe the use of fees in individuals with tracheostomy as well as individuals who are critically ill. We also know that fees is very useful in the identification of oropharyngeal secretions, so secretions that are pooling in the pharyngeal recesses. Murray and colleagues have shown that these secretions are predictive of aspiration. So we may use that information from our fees to inform prognosis and also make a plan for treatment. Some interim conclusions then. First, we want to be cautious in our interpretation of the modified Evans blue dye test, being mindful that this test is not able to detect trace aspiration, and that may be important clinically in some of the patients we see. We can use pulse oximetry as an adjunct to our clinical examination, but again, being aware that there are variables that can cause episodes of desaturation, and that desaturation is not only because of aspiration. And then finally, fees is a viable instrumental option. One important feature of fees is that we can identify those oropharyngeal secretions, and also we can use fees and obviously not take the patient to radiology. So we obviate that need to take a very complicated patient to radiology for evaluation. I'll move on now to talk a little bit about the use of speaking valves in this patient population. There are many case reports as well as case series showing that speaking valves are useful in minimizing and sometimes eliminating the occurrence of aspiration in individuals with tracheostomy. In 1999, Steve Leder reported, however, that patients continued to aspirate with valve use or did not aspirate for both valve on and valve off conditions. More recently, Suter and colleagues showed that we need to consider bolus type when looking at the effect of valving. So they found that cuff inflation status, whether the cuff was inflated or deflated, did not have an effect on laryngeal penetration and aspiration. But they did find that the use of valving eliminated aspiration of thin liquids. Another recent reference shows that speaking valves facilitate vocal fold adduction, help to maintain the glottic closure reflex, and clear the upper airway. So this reference speaks to many of those implications of tracheostomy that I mentioned earlier in the webinar. We know that oral hygiene is another important piece of care of patients with swallowing disorders. There's an extensive literature documenting the importance of oral hygiene. We have references from Susan Langmore as well as Terpenny and colleagues that show that maintaining oral hygiene is useful in facilitating a reduction in the occurrence of aspiration pneumonia. This, of course, requires attention to very small details of patient care. We increasingly consider aspiration pneumonia to be a preventable illness, and the oral hygiene piece, although a small detail of patient care, has important implications. There are references too that show that with instituting an oral hygiene program as well as formal dental hygiene programs, professional dental care, that there's a reduction in pneumonia rates as well as mortality associated with aspiration pneumonia. So, a couple of interim conclusions again. Individualized evaluation of the effect of valving on aspiration is important, so we want to consider particular bolus types as well as our individual patient, again remembering that the underlying mechanism of aspiration is likely multifactorial in this patient population. We want to reinforce oral hygiene and then finally consider the multifactorial nature of our swallowing impairment, perhaps keeping in mind the disuse atrophy that can occur in this patient population after prolonged intubation or prolonged ventilator support that delays a return to oral intake. In your slide, I've included it takes a village piece that details many of the different aspects of patient care that need to be provided to this complex patient population. I think it's obvious from that slide that no single individual can provide all of the education that is necessary to take care of these patients. Speech-language pathologists are an important part of that team. Our education, the focus of our education varies depending upon the situation in which we encounter our patients. So in the acute care environment, we are often educating patients about the role of speech-language pathology, explaining the effect of tracheostomy and ventilator support on speaking and swallowing, reviewing relevant anatomy and physiology with our patients and their caregivers, and then explaining the results of our evaluation and the need for long-term speech-language pathology follow-up. We want to prepare our patients at this point for rehabilitation, hospitalization, and the need for long-term therapy to improve speech and swallowing. In the rehabilitation setting, whether that's in acute rehabilitation or in a subacute facility, we are focusing on facilitating independence, and that independence can take many forms. Patients can learn to inflate and deflate their cuff. They learn to apply and remove their speaking valves. They become knowledgeable about appropriate diet and any swallowing compensations. So patients, we want them to be active participants in their care and direct their care. In the outpatient setting, speech pathologists are providing long-term follow-up. It's important for us to provide appropriate sources for patients to continue to be informed about tracheostomy and ventilator care. We may provide some online sources to patients that we have vetted for appropriate content. And then finally, I'll just conclude by talking about the team approach and just reinforcing that we know that a larger proportion of patients receive speaking valves when a team approach is initiated. We also know that there's a decreased time to initiate the trials for speaking valves and decreased time to initiate downsizing of tracheostomy cannulas, as well as a decrease in the time that patients await decannulation. So there are many important improvements in patient care that are a result of the team approach. So thank you very much for your attention, and I hope that there is clinical information from this webinar that you will be able to use in your practice.